Welcome to Board Pearls. This is episode 2 of 5 of the chronic pancreatitis, cysts, and neoplasms chapter in the pancreatic and biliary disease module. This episode is chronic pancreatitis management and complications, enzyme replacement for exocrine insufficiency, the pancreatogenic diabetes with its hypoglycemia-prone physiology, and the anatomic complications from pseudocyst to splenic vein thrombosis. 3 threads run through this episode, and all 3 are consequences of the same parenchymal loss the last episode set up. The acinar cells die, and the gland stops making enzymes, which is exocrine insufficiency. The islets die alongside them, and the gland stops making insulin and glucagon, which is pancreatogenic diabetes. And the fibrosis and ductal disruption that replace the parenchyma produce a set of anatomic complications, each one traceable to the local anatomy. The teaching is that the management of each thread follows from the mechanism that produced it. Start with exocrine insufficiency, because the threshold for clinical disease is the first piece of mechanism worth understanding. The pancreas has enormous reserve, so steatorrhea and weight loss don't appear until exocrine output drops below about 10% of normal, and the same threshold governs deficiency of the fat-soluble vitamins A, D, E, and K, which is why a fecal elastase can be modestly low with no clinical malabsorption, and why a patient who actually has steatorrhea has lost roughly 90% of acinar capacity. So clinical exocrine insufficiency is a statement about how far the disease has advanced, not just about which test came back abnormal. That reserve principle also explains why bone density belongs in the baseline workup, because vitamin D malabsorption layered on the bone turnover that smoking drives produces a high rate of bone disease. And catching it early matters because enzyme replacement started early may prevent or reverse the bone loss, so the visit where you diagnose insufficiency is the right visit to order the bone scan. Enzyme replacement dosing is built around the substrate the enzyme has to act on. Lipase needs food in the duodenum to digest, and if it arrives without chyme, it just gets degraded and accomplishes nothing, so the dose goes with the meal, not before and not after. And taking it at the wrong time looks identical on paper to taking the right dose while producing apparent treatment failure for a reason that has nothing to do with the dose. The starting dose is 40 to 50,000 lipase units with each main meal, and half that with snacks, landing around 10 to 25,000, and the conversion to remember is that 1 international unit equals 3 of the USP units the products are usually labeled in. So an internationally labeled product is multiplied by 3 to compare against the target, with titration up to about 90,000 per meal by clinical response. When response is inadequate, the workup is structured rather than guessed at. The first move is to escalate the dose. The second is to add a proton pump inhibitor, and the mechanism is worth holding. Non-coated lipase is inactivated by stomach acid before it reaches the duodenum, and the enteric-coated microsphere products only solve that if the duodenal pH is near neutral because the coating is designed to dissolve at neutral pH. But in chronic pancreatitis, the duodenal pH is often persistently acidic because bicarbonate secretion has dropped along with the enzymes, so a proton pump inhibitor raises the pH enough for the coating to release the enzyme where the chyme is. After dose and acid suppression, you verify adherence and meal timing, and then you exclude the competing causes of diarrhea that mimic enzyme failure, meaning small bowel bacterial overgrowth, bile acid malabsorption, celiac disease, and mucosal disease, none of which respond to more lipase. And monitoring deserves one careful point. Repeating a fecal elastase after replacement is started doesn't reliably reflect ongoing endogenous function because the assay doesn't cleanly separate the exogenous enzyme from the endogenous one, so titration is driven by weight trajectory, stool consistency, fat-soluble vitamin levels, and fecal fat when the picture is unclear, because symptoms alone underperform since patients adapt to chronic loose stool and underreport. That brings the diabetes, and a central teaching is that this is not type 2 with a different cause label attached, because the underlying physiology differs in a way that changes management. The fibroinflammatory injury that destroyed the acini also destroyed the glucagon-producing alpha cells and the pancreatic polypeptide cells alongside the insulin-producing beta cells, so the patient loses insulin, but also loses glucagon, and almost every clinically relevant feature follows from that. Glucagon is the normal rescue from hypoglycemia, so without it, a patient who gets slightly too much insulin has no endogenous brake, which makes this diabetes brittle in a specific way, with hypoglycemia more frequent, deeper, and harder to predict than in type 2, so insulin titration has to be conservative, not because the patient needs less insulin overall, but because the safety margin around any dose is smaller. The same mechanism explains why sulfonylureas are a poor choice, because pushing more insulin out of an already depleted beta cell mass without restoring counterregulation adds hypoglycemia risk without addressing the deficit, whereas metformin remains a reasonable adjunct and may even carry a modest cancer risk reduction signal that matters in this population. So the drug to avoid is the sulfonylurea, not the metformin. The GLP-1 receptor agonists are a separate caution, driven by acute pancreatitis history rather than the chronic disease itself, because in a patient with prior acute episodes, the unresolved recurrence risk is enough to steer away from the class. The distinction from type 2 is built on the same mechanism, a lower body mass index because there's no metabolic syndrome driving it, a lower C-peptide because the deficit is beta cell loss rather than insulin resistance, no metabolic syndrome features, and concurrent exocrine insufficiency on the same workup, because the fibrosis that killed the islets also killed the neighboring acini. So a patient who looks like type 2 but has a normal weight, a low C-peptide, and steatorrhea is being miscategorized. Monitoring layers on. Fat-soluble vitamins and bone density matter because they compound the diabetic risk profile. And B12 deserves a separate check because exocrine insufficiency interferes with the enzymatic step that frees B12 for absorption in the duodenum. A quiet deficiency that gets missed if you only think about fat-soluble vitamins. That covers the metabolic consequences. The rest is the anatomic ones, and the organizing principle is that each complication arises from a specific structural problem and the management follows the structure. Pseudocyst is the most common, in about a quarter of patients and most often in alcoholic disease, defined by a fibrous non-epithelialized wall and a collection that has matured at least 4 weeks beyond the acute event or arises from ductal disruption in established disease. And maturity matters because an immature collection without a wall won't hold a drain, so the 4-week threshold is the operational definition of when it can be drained reliably. The first question is whether to drain at all, and the answer is driven by symptoms, not size. So asymptomatic pseudocysts are observed no matter how big, because most resolve on their own and the procedural risk exceeds the expectant management risk in a patient who isn't bothered, while you drain for symptoms, infection, or rapid enlargement, with pain, gastric outlet obstruction, and biliary obstruction, the symptomatic indications. When you drain a mature collection, the preferred approach is an endoscopic ultrasound-guided cyst gastrostomy or cyst duodenostomy with a lumen-opposing metal stent, whose dual flanges hold the cyst wall and gut wall together, and whose wide internal diameter, 10 to 20 millimeters, lets debris out and lets the scope pass back through for necrosectomy when there's solid material, with randomized data putting it on equal footing with surgical drainage in a shorter stay, and high long-term success overall, though complication rates are higher for walled-off necrosis, because solid debris drives recurrence and infection. Disconnected duct syndrome is the anatomic exception inside the pseudocyst topic, tested precisely because standard pseudocyst management fails, because the proximal duct is anatomically severed from the distal viable segment, and that distal segment is still alive and still secreting into a fluid space with nowhere to drain. So if you pull a transient stent, the disconnection reforms a collection as the tract collapses and the secretion reaccumulates. It requires permanent transmural drainage with a retained long-term stent or surgical resection of the disconnected segment, with MRCP first to delineate the ductal anatomy, so the plan is built on a clear picture, while transpapillary stenting alone is reserved for the narrower cases of a communicating pseudocyst with an intact duct, a duct disruption with ascites or fistula, and pseudocyst with strictures or stones. Distal common bile duct stricture is the second complication from peripancreatic fibrosis at the head compressing the bile duct as it passes through, presenting as progressive cholestasis, managed with a fully covered self-expanding metal stent for a 6 to 12-month dwell that must come out before epithelialization makes extraction impossible, with biliary bypass surgery the next move when endotherapy fails, or when head calcifications make a durable response unlikely because the fibrocalcific stricture won't yield reliably to dilation, and a new bile duct stricture in chronic pancreatitis still requires cancer. Splenic vein thrombosis is the third complication, and the venous anatomy carries the whole teaching. The splenic vein runs along the back of the pancreas. Peripancreatic inflammation thromboses it, and once it's obstructed, the splenic outflow has to go somewhere, which is retrograde through the short gastric veins into the gastric fundus, producing isolated fundal gastric varices and what we call left-sided portal hypertension. This is a fundamentally different situation from generalized portal hypertension, which is a pressure gradient between the whole portal system and the systemic circulation driven by hepatic resistance and treated by lowering that gradient. Left-sided portal hypertension is local, with high pressure only in the splenic outflow and the spleen as the high-flow inlet driving the varices. So if you take the spleen out, the high-flow inlet disappears, the varices decompress, and the bleeding stops, which makes splenectomy curative when these varices bleed, the diametric opposite of how you'd manage a fundal varix from cirrhotic portal hypertension. And anticoagulation here is reserved for clot extending into the portal or superior mesenteric vein, where the territory at risk has expanded beyond the splenic vein alone. Pancreatic ascites and pancreatic pleural effusion are the fourth category and share a mechanism. A disrupted duct or fistulous tract leaks pancreatic juice directly into the peritoneum or tracks retroperitoneally into the chest, and the diagnostic move is a fluid amylase, because a markedly elevated amylase in ascites or a pleural effusion in a chronic pancreatitis patient, with management treating the disruption directly, a transpapillary stent across the leak when the duct is intact above and below it, and transmural drainage when it's a true disconnection. The same principle as pseudocyst with disc, and pseudoaneurysm is the complication that hides inside the others, because the gastroduodenal and splenic arteries sit right next to the inflamed gland, and their walls get eroded by the enzymatic milieu of a pseudocyst or necrotic collection, presenting as GI bleeding, sudden enlargement of a collection, or an unexplained hemoglobin drop diagnosed by pancreas protocol CT, and the rule that matters most is that embolization is required before any necrosectomy or cyst drainage, because manipulating a collection that hides a pseudoaneurysm risks catastrophic hemorrhage, the same rule as in the long-term consequences attached to severe, acute, or chronic disease as a whole. Exocrine insufficiency develops in about a quarter of patients after necrotizing pancreatitis, which is why this episode opened with enzyme replacement. Diabetes runs at roughly twice the population rate, which is the pancreatogenic diabetes threat again, and pancreatic cancer lifetime risk is around 4% across chronic pancreatitis overall, concentrated in the hereditary form and in smokers. So routine surveillance is not recommended outside the genetic context, because the absolute risk. So the shape of the episode is that three threads, all traced to the same parenchymal loss. The Ascini fail and enzyme replacement stands in. Dose to fat intake, given with meals. Titrated by objective response, with a proton pump inhibitor added when duodenal pH defeats the coating. The islets fail and produce a diabetes whose hypoglycemia risk is the dominant management feature, where conservative insulin and metformin are reasonable, and sulfonylureas are the class to avoid. And the structural disruption produces complications whose management is read off the anatomy. Drain symptomatic pseudocysts with a lumen-opposing stent, and recognize disconnected duct as the exception, stent or bypass a distal bile duct stricture from head fibrosis, take the spleen out when left-sided hypertension bleeds, treat pancreatic ascites at the disrupted duct, and embolize a pseudoaneurysm before touching the collection. Episode 3 turns to the immune-driven and cystic pancreas. Autoimmune pancreatitis types 1 and 2 with their diagnostic criteria and steroid response. The cyst differential of pseudocyst versus mucinous cystic neoplasm versus serous cystadenoma versus the intraductal mucinous neoplasms, told apart by fluid markers and imaging, and the surveillance of those mucinous neoplasms. The question shifts from what the failing gland does to its host toward what a discrete lesion in the gland means and how you decide whether to watch it or resect it. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 2 of 5 of chapter 26, and I'll see you in the next one.